thank you for joining on time. I know I already sent out a message to all our writers about um, this clinical skills opportunity that we get to learn from. And I know in the past we've done more interviews, but I think it's just really important that as a lot of us do want to enter medicine, that we also learn about some basic skills from people who are actually actively in med school. So yeah, we have the great opportunity for another great collaboration. And yeah, today we're just going to learn about some clinical skills like what physical exams are. I think we all get them from our primary care physician, and like vital signs and just more like basic information and some introductory information that a lot of students in med school actually need to learn. So, yeah.
Great. Thanks for setting that up, Maya. Hi, everyone. My name is Benjamin Popokh. I'm a third-year medical student at the University of Texas Southwestern Medical School. It's in Dallas, Texas. And like Maya said, I'm going to be talking about clinical skills. I'll try to give you guys a good introduction covering how to take a good patient history, conduct a physical exam, as well as what vital signs are, which ones to look out for, appropriate ranges, and more. So a little bit about me. Like I said, I'm a third-year medical student, and although you probably have heard a lot about medical school and getting there, it's very difficult, takes a lot of time studying, but you do have time to have fun. On the left is our medical student running club. We brought Hoka out and we had some shoe demos. We all hung out for a while at a coffee shop where we do our runs. And on the right is myself with some of my medical student peers at a camping trip that we organized. So while it's important that you guys get ready to bunker down and study and work, know that you can still have fun even during the process. A little bit more background. I'm from Plano, Texas. I went to Plano West Senior High School and then went to college at UT. So if any of you guys are thinking about being Longhorns, hook 'em. And just some more pictures proving that we can have fun in medical school. On the top is my friend group during our white coat ceremony. This was right after you get your white coat, which is a big step in becoming a physician. And in the bottom is a 5K that we helped organize with one of the orthopedic surgeons here at UT Southwestern. I studied neuroscience and biology, and a lot of people ask about gap years and gap semesters. I took a bit of a gap semester. I graduated one semester early, so I had the spring off and I worked as a EMT, emergency medical technician, so an ambulance driver. So let's get into the talk. What are clinical skills? And as I'm talking, please feel free to put some comments in the chat. I think that I'll finish well under the hour, so there will be some time for Q&A, questions, anything that comes up. I won't answer them live. I'll probably just let them build up so we can go over, but nonetheless, feel free to type them out. So what are clinical skills? I've already put here my answer. Techniques used by doctors, nurses, other healthcare professionals to understand and help their patients. The main ones that we'll be talking about are taking a history, which is asking questions, just like history class is figuring out all the facts and details from past events. Doing a physical exam, so checking the body. Sometimes this can be very general, if this is something like an annual exam, where you just want to make sure everything's going well, or it can be what we call focused, where we're focusing on a particular organ, body system, maybe even one eyeball versus the other, depending on what the patient complaint is. And measuring vital signs. Why are they called vital? Because they are the important signs that can tell us if someone is in shock, if someone is in sepsis, which means infection. So we want to see, using our vital signs, how the body is functioning, what kind of things it can tell us. So why these are important? The vital signs from the very beginning can start to tell us, is this patient sick or not sick? That's a really important thing to be able to decide. Eventually, you'll be able to build up just by seeing a patient walk in the room. This patient is sick. They need to be admitted to the ER, to the inpatient service, etc. Sometimes it's not as clear, and we need some more details from our history, from our physical exam. And beyond that, especially when you're doing a well child or a well patient visit, and you're just checking everything, asking questions, but they're not immediately sick, doing all of these steps helps build trust. It's really important that the patient knows you're there with them. So if they show you, I have pain here, making sure that you point to the area or you touch and you confirm. So you're having pain here. shows that you're listening, shows that you're feeling with them, that you're being empathetic. And of course, it helps you make good decisions. You have to know all the details to be able to make a good diagnosis. You have to see the physical exam to know what you're dealing with, and you need to know the vitals to ascertain whether or not this patient needs outpatient treatment, meaning they can go home if they need any treatment at all, or they can just be reassured, or if it's something critical that sends them to the hospital. So let's go step by step. I said one of the first parts of clinical skills is taking a patient history. And this is all about learning the story. Eventually, as you practice more and more, this is really what it feels like. It feels like you're getting a story. It doesn't feel like a rubric where you're checking each box off. At the beginning, it'll feel that way, but eventually it'll become much more natural and fluid with it. So, how you break down the patient history. The main part goes first, a chief complaint, or a lot of people are starting to call this a chief concern. This is when the doctor is asking you, how can I help you today? Or what brings you into clinic today? Or what's bothering you? This is the first thing that you're saying when it comes to mind. It might be something just one off. For example, I'm feeling not well. I think I might have the flu, or I've been throwing up, or I broke my arm. Or it can be all those things together. If someone's coming in for an annual visit and they haven't been seen in a while, they may have 10 different things in their chief complaint. When we have that come up, we try to narrow it down by doing priority setting. So what that means is that if someone tells me that they've got 10 problems, I say, I want to hear about all of them, but for me to be most effective, I'd like us to make a priority list. Can you please tell me 2 or 3 problems that you want to make sure are addressed today? And then we'll take care of the other ones at follow-up visits. So agenda setting and priority setting, really, really important so you're not overwhelmed. The next thing you need to know is the history of the present illness. So if they're telling you about something immediate, that they broke their arm, that they're vomiting, that their leg feels numb, you want to know details about that. And we're going to get into how you can learn those details in just a second. But that's called the HPI, History of Present Illness. Other things in the history that you need to know are the past medical, surgical, family, and social histories. So past medical history, this is learning things like if the patient's been pregnant before, if the patient has had any kind of infections before, if they've broken bones before. You want to know things that are both relevant and maybe irrelevant, but could possibly come up when you're dealing with the present condition. You want to know about surgeries. For example, have they gotten their appendix removed? The appendix is a little organ that sits in the bottom right of your abdomen. It's called an appendix because, like an appendix in a book, it's kind of an extra part. It hangs off. So if you've ever seen a book with an appendix, that's an extra part. Like an appendage is an extra body part. And so if you know that, then when someone tells you that their chief complaint is that my belly hurts in the bottom right, once you ask, have they had an appendectomy or removal of the appendix, it actually helps you with your diagnosis because you know it can't be appendicitis, inflammation of the appendix, because they don't have one. So it's really important. If you had missed this, you might have thought, oh, it's obviously appendicitis. But now that you know, you can rule it out and move on to some other diagnoses. Past family history can be really important, especially when you're getting concerned for things that could be hereditary, like different cancers. If someone tells you that there's a really strong family history of breast cancer, colon cancer, that will change the way that you make your diagnoses. It'll change the labs that you order, the imaging tests, and more. One that's really starting to emerge right now is this past social history. This used to be something doctors, nurses, students never asked about, and now we know it's so important because knowing what kind of work someone does can give you hints about different diseases. There's a whole branch of lung diseases that are associated with different jobs. There's sheep herder's lung, so only associated with people that herd sheep. There's lung diseases associated with people who work with birds and more. So that social history, knowing what they do for work, what the home environment is like, do they feel safe at home, are all very important. This is also where we would ask about 3 really big things. Those 3 things are tobacco. So if they're using cigarettes, vapes, patches, any other kind of tobacco products, alcohol, how much they're drinking if they drink, as well as any other drugs. Sometimes it can be a little bit uncomfortable to ask people straight up, are you using any illicit drugs? Are you using any illegal drugs? So I like to go into it a bit softly. I'll ask, are you using any medications not prescribed to you by a doctor? And they might tell me, yeah, I'm taking some of these herbal supplements, I'm taking some of these vitamins. And I say, okay, anything else, anything like marijuana, cocaine, etc. But you kind of ease them into it, knowing you're asking about drugs, medicines that may not be prescribed to them formally. Last couple things here, you want to know their medications that they're taking, because this can be important to know what kind of medications you can give them. And it can tell you if someone says that their shoulder's been hurting and they've been taking ibuprofen or an anti-inflammatory for a few weeks and it doesn't help. It might be something that's not related to inflammation then if that doesn't seem to be helping, or it's not strong enough, or there's something chronic going on. So medications are really important to know in your history, as well as allergies. Are they allergic to any medications? This is going to influence what you can actually do for them, right? So you want to make sure you know their allergies before you start making suggestions about medications, tests, or anything else. Finally, in your history, you want to do a review of systems, an ROS. So systems refer to the different organ systems. So you might be thinking like GI, gastrointestinal. You might be thinking about the brain, the nervous system, the heart, cardiovascular. And you can come up with a set of questions for each one. For example, are you having any headaches, vision changes, nausea, vomiting, so and so? At first, you might just ask a huge battery of questions. You'll just be throwing out any question that comes to mind. But eventually, as you start having a better idea about your potential diagnoses based on this previous history, you might ask some more refined or targeted questions. Again, feel free to put any questions in the chat. I won't answer them live right now, but I'll get to all of them at the end of this lecture. So I told you I would give you a way to remember the history of present illness questions. And this pictured here is an old cart. Old carts is the mnemonic or memory device that we use to think about what kind of questions we want to ask. Each letter stands for something different that we ask. The O is onset. So someone tells you my head hurts. My first question is going to be, how long has your head been hurting? Pretty simple, right? You want to know, did it start today because you tripped down some stairs and banged your head? Has it been going on for a year? Has it been going on for 10 years? Has it been getting worse? So O is onset of disease. The L is location. So again, we can stick with our head hurting example. Someone tells me their head hurts. I say, how long has it been going on? And I say, where does it hurt? Can you point to it with a finger? Or is it more like a hand? It's all over the place versus, oh, it's just right here. The D is duration. How long does it go on whenever it comes up? So for example, they say that they have a headache and we find out it's been going on for a month. It's in the back of the head. And whenever the headache comes on, it lasts 10, 15 minutes and goes away. Or they could tell you it lasts an hour. All those things are going to be helpful in our diagnoses. This C is characteristics. What does it feel like? Is it sharp, burning, pressure, dull, right? So you want to know what this feels like. The A and R go together. This is aggravating. So when you're aggravated, it means you're bothered, right? So I want to know aggravating. What aggravates this condition? Do lights make the headache worse? Do sounds make the headache worse? Do certain foods make the headache worse? So and so. The R, again, I said these go together. The R is relieving, things that make it feel better, give you relief. Do certain pills seem to make it feel better? Does taking a nap make it feel better? Does eating some food make it feel better? So R is relief. The T is timing. Does it happen in the morning, the afternoon, evening, randomly? I want to know when it's happening if there's a pattern. And the S is severity. This is your classic on a scale of 1 to 10, how bad does it hurt question. The important thing about the severity is that if we keep seeing this patient and we're giving certain treatment, we can say every time, okay, it was an 8, then it was a 7, then it was a 5, then it was a 3. So we're doing something right. Or they might tell you every single time it's a 10 out of 10, it's a 10 out of 10, it's a 10 out of 10. So we're clearly not helping them. We're clearly missing something about the diagnosis. I saw that at some point while I was talking, someone raised their hand. I said this a bit earlier, but feel free to drop some comments in the chat. For the sake of getting through the lecture, I'm just going to talk through it, and then I'd be happy to answer any questions. I think it was V that raised her hand. So Feel free to drop some questions or save your question for the end. Next step, physical exam. So we've gone over the history. We've gone over the history of present illness with old cards. Now we want to think about our physical exam. This is using all your physical senses, sight, touch, hearing, maybe even smell, to get some clues about this patient. So some common things, you want to look at this patient, of course. You don't want to go in with, blind eyes. And this could be as simple as when you walk in the room, the very general inspection of the patient, to more detailed inspection. If you're looking at the fingernails, if you're looking inside the ears, right? So this device on the bottom right is called an otoscope. Oto means ear, and scope is to look into it, like a microscope is to look at small things. Feeling, the word for this is palpation, not to be mixed up with palpitation, which is when you can feel your heartbeat. Palpation is touching, right? So if someone says they have a bump, a lump, a rash, you want to know, is it rough? Is it scaly? Is it moist, right? So you want to palpate and know what you're dealing with. This is an interesting one. If anyone does band or drums, the percussion line are the drummers, and you can actually tap, you can percuss to try to help build your diagnosis. So there's conditions, for example, where you build up some fluid in your belly, and you can actually tap, kind of the same way you look for studs in a wall, or you tap to hear where the wall is hollow, and you can tap and listen to the belly. You can also use this to feel for the liver, which is a big organ on the top right of your abdomen, the upper right quadrant, or you could feel for your spleen, which is in the upper left quadrant. And if either of those are enlarged, then you'll be able to percuss them as you tap along the belly. And finally, and this isn't limited to this list, there's many more options, but you want to listen. The fancy word for this is auscultation, auscultating. This is your classic using a stethoscope, taking a listen to their heart, lungs, and even their stomach. There's different criteria for different stomach sounds. You can have a hyperactive, a hypoactive bowel, normoactive. So listening is really important, and just listening to your patient when you take the history. But again, you have your otoscope in this bottom right to look into the ears. You have your stethoscope. So again, scope is to kind of look into something, and stethos refers to the chest in this case, though you can listen to other things. And then in the top right is a reflex hammer. So this is what you're using to feel for reflexes. You can feel if they have hyperreflexia, if their knees are really jerking. You can check on the arms, all over. So finally, vital signs, measurements of how your body is doing. The main vital signs that we consider are the heart rate. So that's your pulse, how many times the heart beats in a minute, the blood pressure, which I'll talk about in a moment, the breathing respiratory rate, so how many breaths you take in a minute, your temperature, your oxygen level, and this is something that people argue about. Some people consider pain one of the vital signs. So like I asked you, the 7 out of 10, 10 out of 10 pain scale, some people consider that a vital sign as well. So here I'll try to get some group interaction. You guys can unmute for anyone that wants to take a guess. Any guesses on what a normal range for heart rate is for an adolescent or adult? Younger kids and babies, it can be a little bit different. So let's just stick with adolescents and adults today. Any guesses on heart rate?
Would anyone be able to take a stab at that?
I can see the chat as well, so I'll monitor that. I see 80 to 100. Okay. Maybe one more guess if anyone has one.
60 to 100.
60 to 100. Okay, great. So everyone was in a good range. So 60 to 100 is considered normal. And this is just based off statistics, 60 to 100. Some people, especially endurance athletes, will live at 50 heart rate. Some people even at 40 heart rate. It's all about how the heart is trained and remodeled. But yeah, 60 to 100 is the general guideline. Anything under 60 we call bradycardia, which means slow. Anything over we call tachycardia. Tachy means fast. Blood pressure. So blood pressure is kind of weird. It takes a while to really understand what these numbers mean. But effectively, what blood pressure is referring to is the pressure that it takes to pump blood through your body from your heart. Your heart is like a big pump. And there's two numbers that we mainly focus on, this top number and bottom number. The top number is called systolic heart pressure, blood pressure, and the bottom number is diastolic blood pressure. Usually people are really concerned mainly about the systolic blood pressure. And what this tells us is when your heart is actually pumping blood out into your body, so from the lower chambers of the heart out to the rest of your body through arteries, how much pressure it's facing. Reasons that this number might go up is if you have cholesterol in your arteries, if you have some plaques, buildups, clots, etc. And so when this number goes up, it's not a good sign, right? So it means that someone might have a heart attack, somebody might have some cholesterol building up. So that top number is the pressure your heart has to fight against, if you want to think of it that way, to get blood out to those arteries. The bottom number is a bit more confusing. It's the filling pressure. So it's the pressure that exists in the heart when it's being filled up with blood. So it's a little bit lower usually. And then this number is just a mathematical mean pressure that they take between the two. It's not actually a mean, it's a little bit skewed, but we won't worry about that today. So really remember the top and bottom number. Does anyone know what we consider a normal adult blood pressure?
Anything less than 120, I think.
Yep. So for systolic, 120. What about that bottom number? What number do we like to see there?
I believe it's 80.
Totally, Zoe. Great job. So 120 over 80 is considered normal. Again, some people live a little bit lower. I have many patients who normally are at 100 over 60. 120 over 80 is considered normal. Different societies, meaning different medical groups, have different guidelines. For example, cardiologists versus family medicine doctors have different standards of when they start to get concerned. But 120 to 129, it's pretty good. We can keep an eye on it. We don't have to do anything. 130 to 140, we start keeping an eye on. We start counseling about lifestyle changes. If they smoke, we tell them some ways they can quit smoking. If they drink a lot, we can lower the drinking. 140 and above, now we're really starting to get into hypertension, so high blood pressure. Okay. If it's low, there can be some problems too. If someone's hypotensive, low blood pressure, they can feel kind of woozy. Maybe if you guys have ever really quickly, especially in the summer, you kind of feel spinny, there's some stars. That's when you're hypotensive because the blood is all rushing. When you stand up, you go from pooled to standing up, and now the blood has to come up your legs and all the way back to your heart. So good, 120 over 80. What about respiratory rate? This is kind of a weird one. We usually don't think about our breathing, and sorry if you guys are all thinking about your breathing now. But what do you guys think a normal respiratory rate is for an adult? Zoe says 16 to 18. Okay. 30.
12 to 20.
Adi says 12 to 20. Okay, so we've got some different answers. Adi's right. 12 to 20 is considered the normal range for a breathing or respiratory rate. Again, this can be influenced by a lot of things. If you're exercising, obviously your respiratory rate goes up, and that's good. That's normal. But when someone's at their baseline, 12 to 20 is about right. When we start getting low, when we start having, this is kind of a weird one, bradypnea. So pnea refers to breathing, and brady, just like heart rate, means slow. There can be some things that are concerning us. For example, and this is a really hard one for you guys. There's a few different types of drugs, but there's one that we really get concerned about that can drop someone's breathing rate and can be really dangerous. Again, there can be a few of them that do this, but there's one that's very common. Any guesses on a drug that drops your respiratory rate? Or a class of drugs?
Could it be like anxiety pills?
Yeah, nice, Maya. Yes. So what kind of anxiety pills are you thinking about specifically?
Like maybe like Xanax?
Yeah, great. So Xanax belongs to a class of drugs called benzodiazepines, which work very similarly actually to alcohol, and they slow down your breathing rate. Great. That one is a reason why benzodiazepines like Xanax, anxiety medication, should never be taken with alcohol because those two together can really slow your breathing rate down. So that's a good example. The other one that I wanted to bring up is opioids. So these are your heroin, codeine, morphine, oxymorphone. These can drop your breathing rate really low, down to like 4 or 5. So you can even imagine taking 4 breaths in a minute. That's 1 breath every 15 seconds. It's pretty bad. And so I think it's important for everyone to know about something called naloxone, which can reverse opioid intoxication. So naloxone, you guys can look that up on your own later. So yes, 12 to 20 for respiratory rate. Things that can make it over 20, anxiety can raise your respiratory rate, of course. Sometimes your rate can go up when you're exercising. That's normal. Let's just get a few more here. So temperature. What temperature is considered a fever? And you can either say it in Celsius or Fahrenheit, whatever you're more used to. So 102 would definitely be a fever.
100.1.
100.1 is getting there. Anything over 100, yeah. So the easy thing you can do is say anything over 100 is pretty much a fever. Technically, we look for 100.4. That's 38 degrees Celsius. It's kind of arbitrary. A lot of these things are just statistics where the averages are. But yeah, 100.4 or 30 Fahrenheit or 38 Celsius is usually fever. And then the normal range, 97 to 99. Anything below or over can still be normal for some people, but 97 and 99 is usually where we like to see people. And then the oxygen level, maybe you guys remember during COVID, a lot of people were talking about using pulse oximeters, where you put a little device on the tip of your fingers and you can see what your oxygen level is at. That's out of a percentage. It's pretty much sending a little light through your finger and using that to measure how saturated the blood is with oxygen, since the blood carries our oxygen. And that we usually like to see from 96 to 100%. So you guys did great. So heart rate 60 to 100, breathing 12 to 20, temperature 97 to 99 with a fever at 100.4, blood pressure around 120 over 80, and oxygen level 96 to 100, 95 to 100. So some things that you guys can do from home, or if anybody is watching this later, you can practice for yourself. How do you count a heart rate? You can use fancy tools, of course, but if you ever need to count it just while you're walking around, if your friend collapses on the ground, or if you come across someone that's on the ground and you need to take their pulse, there's a few places you can check. A really easy one is at the neck. That's called your carotid. And so you want to kind of find the center of your neck. You guys can all practice this if you'd like. And just to one side or the other, kind of next to the Adam's apple, a little bit above it, if you press your fingers down, you should be able to feel a pretty big pulse, or else you might be a zombie or vampire. So you guys can move it around and try to find it. Try not to press 2 at a time. If you accidentally cut off the pulse for too long, you can faint. So just one or the other. The other easy one, if you don't want to, grab someone by the neck, is the radial pulse. This one can be a little bit finicky, but you should be able to move around. And I think it's really good for everyone to know where their radial pulse is. Sometimes when I'm bored, I just take my pulse if I'm waiting in line or waiting in traffic. So you want to find your thumb. You kind of follow it down. And then underneath, there's kind of some bones you can feel here if you're following my wrist. And then there should be a little groove where you can feel your radial pulse. Again, it can be hard to find. It took me a while when I was first learning. But once you find yours, you should know where it is forever. And you want to find how much you need to press. If you press too deeply, you'll actually cut off the blood flow and you won't feel a pulse because you stop the blood flow. If you press too lightly, you won't feel it either. So you want to find that Goldilocks spot in the middle. And so if you guys get bored at some point during this lecture, you can spend a minute and take your pulse. And it's as simple as just counting the amount of beats in the minute. Your breathing rate, as simple as it sounds, how many times you breathe in a minute. If you don't have a minute to spare, you only have 30 seconds, you can just count for 30 seconds and multiply it by 2. That works as well. If you're really in a time crunch, you can count for 15 seconds and multiply it by 4, but that starts to get a little bit variable. Temperature, you'll use a thermometer, or worst case, you can try to feel someone's forehead. Blood pressure, you'll use a blood pressure cuff. which another time we can talk about how those work. And then oxygen level, you would use a pulse oximeter. So I know that's a lot of information. This next step, I want to get back to interactive. I'm going to ask you guys to help me work up a patient. So we're in clinic, and a 16-year-old boy comes to visit you, and he is giving you a chief complaint, a chief concern of a sore throat. What are some things that you think you should do first anytime someone comes to clinic? And you can even use your own experience when you've come to clinic. What are some of the first things they do for you?
Let's take a step.
Ask your symptoms and maybe your pain level before physically examining you.
Great. Yeah, I think that's a good idea, Adi. Anything else you look for?
Asking how long your throat's been hurting.
Great. So you're thinking about those old cards question. I see V also says how long's it been hurting?
Also like taking his vitals too and like temperature.
Yes. So this might have been a little bit of a read my mind kind of question, but Amina got exactly what I was thinking about. The very first thing is going to be looking at some vital signs. So a lot of you guys probably have experienced this when you go to the pediatrician, the nurse comes in or the medical assistant and they take your blood pressure, your heart rate, your temperature. And like I was saying earlier, this is really important because it makes a big difference when someone comes to my clinic and they have a temperature of 104 versus a temperature of 98 with a sore throat, right? It's already influencing the kind of questions I'm going to ask later and what I'm thinking about. But all the other things you guys pointed out are 100% correct in terms of the first few questions you want to ask. So take vitals first. That's going to give us a good idea of what we're walking into. And then things that we should ask. So let's see if we could run through that old carts mnemonic because we already got the chief complaint. He's saying I have a sore throat. So let's see. Can someone give me the L? Because we already did the O. The O was onset. We said how long does it hurt? So what about the L? What's the next one?
Location?
Location. Great job, Zoe. So it makes a difference, right? If someone says I have a sore throat, you want to know, does that mean that when you swallow, you can feel it inside? Is it on one side or the other of your neck? Is it just all over your neck and even radiating to the back? Those things are really important to know what you're dealing with. How about the D?
Duration.
Duration. So when this comes on, when you have this pain, is it all day? Has it just not stopped? Or does it seem like it comes on and kind of comes and goes for an hour? I gave it away. C is characteristics. So describe how your throat hurts. Is it sharp? Is it tingly? Is it ticklish? Is it stabbing, painful, et cetera, et cetera? How about the A and the R? Remember I said that those things are coupled together. What was the A?
Aggravating factors.
Aggravating factors. Amazing. So does it seem to hurt when you're drinking something hot, when you're drinking something cold, when you eat, when you talk? What kind of things make it worse? And then what about the R? Since I said these are paired together, you guys might be able to guess it. So
Relieving factors.
Great, Sophia. Relieving factors. So what things make it better? Does tea make it better? Does honey make it better? Does rubbing it make it better? What kind of things have you noticed help? Any medications? T is timing. So does it hurt all day or does it hurt just in the mornings, right when you wake up? Does it hurt only at night when you're lying down to bed or during the day? And finally, S is severity. How bad does it hurt? This is going to give us an idea. If this 16-year-old tells us it's 10 out of 10 today and we ask them to follow up in a week, if it's still a 10 out of 10, that should make us curious. Why is this throat so bad so long, even despite medications that we've given? So we want to know severity so we can continue to follow up. And last one, what kinds of physical exams do you think you should do? And of course, there's some more questions we could ask, but I want to make sure there's time for y'all to ask me questions. So we'll skip ahead to physical exam. What kind of things might you check? You can try to guess anything from head to toe.
Check for swollen glands and
Sure.
look inside the throat.
Yes, so we want to look inside the throat. Can we see some swollen tonsils or glands? So that's our inspection. And then we want to feel, we want to palpate. Do you have any swollen lymph nodes in the area? Do you feel an enlarged thyroid, enlarged parathyroids? There's a lot of stuff in the throat. So it's good to see what we're dealing with and feel what we're dealing with. Very good. Other things you can look for would be if the uvula is deviated to one side or the other. That might tell you that there's kind of a mass or an abscess building up. You want to listen to their voice. It can actually give you a few hints. If their voice sounds muffled, it might lead you to thinking about an abscess as well. Some other things that you might want to feel or look for would be neck stiffness. There's something called meningitis, which is inflammation of the covering of the brain that can cause neck stiffness when they bend or move their neck. And that's a really critical one to not miss. Other kind of things that would be hard for you guys to know, but you'll start learning as you build up your illness scripts or your diagnosis scripts, is you want to look at the skin. You want to see if they have any rashes. There's certain diseases like scarlet fever that can cause sore throat as well as a rash. So if you see a rash, it gives you a hint into what you're dealing with. You also want to listen to the heart and lungs to make sure there's no systemic illness. And then one more that you guys could think to feel if you want to percuss or tap is feeling for the spleen. Now, there's one disease that causes an enlarged spleen that can also cause a sore throat and some general feelings of crumminess. If you have this disease, usually you're asked not to play any sports because there's a risk that your spleen could rupture if you get hit, for example, during football. Sometimes they call this disease the kissing disease, very common in teenage, college age, and young adult populations. Does anyone have an idea of what disease I'm thinking of?
Mono.
Mono, yes, infectious mononucleosis. So someone with a sore throat, you should always feel for the spleen and feel if it's enlarged, because that patient will need some treatment for sure, and you'll need to make sure that they're not doing any dangerous activities, behaviors, because it's very possible that their spleen could rupture when they have active mono infection. Great job, guys. I think we worked this patient up pretty well. And so just to give you guys a few last points about how you can start practicing some of these clinic skills, volunteering at clinics, hospitals, and nursing homes is a great way to get started. I know that sometimes clinics and hospitals can be difficult to get into. So try to work through family, friends, anybody that you know, ask around if they can get you into somewhere private maybe, or a smaller clinic where there's a little bit less hassle of taking students. You guys could also consider clinical classes in your high school. Some schools have options for professional development classes. You might even be able to get your certified nursing degree, a CNA. You can watch health education videos online. There's a billion of them out there on YouTube. This is a new one that I've started to include when I give these kind of talks, but asking ChatGPT to make up patient scenarios. On the right, I have a completely it took me 2 seconds, make up a random patient scenario so that I can practice taking history and physical. And you can play for hours with this if you want. So they gave me a patient, their age, their chief complaint, and I can ask any questions. So what are her vitals? And they give me her vitals. I can then go through my old carts. I can go through my medications, allergies. It's pretty cool. Other things you can do is everywhere you go, practice observation. Try to notice the things around you, notice details about people, places, structures, and imagine in your head how you would describe them. And finally, just staying curious, asking a lot of questions whenever you're shadowing, whenever you're volunteering, and anytime you have an opportunity to learn, just ask questions over and over. It's always better to ask than to stay silent. So that's all I've got. I appreciate you guys taking some time on your weekend to learn about clinical skills, including history, physical, and vital signs. If anyone has questions, I'll put it in the chat as well, and you can feel free to share, but this is my academic email, benjamin.popokh@utsouthwestern.edu. I'm always happy to help out, whether it's with college admissions, thinking about medicine, if you have questions about it as a career, how you can get there. So please, please, please reach out. And otherwise, I will stop sharing and take any questions that you guys might have. So, Maya, I don't think that we had any pending questions in the chat, so I'll just go ahead and go with people who raise their hands, and as we do that, if other people want to ask questions, please feel free. Sombriti, I see you have your hand up.
Yes, hi. So I had a question regarding the academic aspect of medical school. How do you like, do you have any advice on how to kind of keep up with the academics while still like balancing like social life and like friends?
Yeah, it's a great question. And I think that this is, frankly, not just for medical school, but relevant right now for y'all in high school, in college, anywhere else, is be really diligent about your time management. So I am almost religious about my Google Calendar. My Google Calendar has everything blocked off. If anyone suggests a date to me, whether it's formal, academic, volunteering, or even just a hangout, I immediately put it in my Google Calendar. And I live and die by that Google Calendar. If it's in the Google Calendar, it's happening. If it's not in there, it's not happening. So I'm really, really diligent, and I check it every day at the beginning and end of the day so that I have an idea of what I'm going into. And on Sundays, I always review for the upcoming week what I need to prepare for. So I think that time management is really crucial. Other things is your mindset. So I think there are things that are non-negotiable in life. Some of those non-negotiables for me do include exercise, having time to eat healthy meals, a little bit of time to socialize. Depending on how busy your day is or your week is, you have less time. But I treat something like exercise and fresh air the same way I treat going to the bathroom, right? You wouldn't say, oh, I'm studying so much, I don't have time to go to the bathroom. I haven't gone in 2 weeks. But you hear people say all the time, oh, I'm studying so much, I didn't have time to exercise or go outside. It should be the same thing. It should be like, you haven't exercised, like you got to go out, you got to keep your brain healthy and fresh. And you just have to decide what is non-negotiable for you. And some of the things like hanging out with friends, it is important for your mental health. It's good for socialization, but there will be times where it just needs to take different forms. Maybe during your exercise, you're running, you run with a friend, and that way you knock out both your exercise and socializing for the day and you can focus on studying. So, big two things: time management, preferably with a calendar, and reframing what things are essential and non essential for you. Let's see. Did we have a question in the chat? Amina says, what do you think makes a great doctor beyond just medical knowledge? Great question. So I personally would not have been a doctor if a few things hadn't happened earlier in my life. I actually would have loved to go into humanities, writing, journalism, something like that. So why do I bring that up? I think that beyond medical knowledge or scientific knowledge, a really important thing that I've noticed with my patients is your humanity, your ability to relate to them, to talk to them, to show that you're there with them and that you care. And majority of patients will take that any day over someone who is the best in the world with medical knowledge but can't talk to you. There's If you get through medical school and you get through residency, you most likely are going to have a good standard for your medical knowledge. And anything after that is extra credit. It's great to be a great doctor in terms of medical knowledge, but you really, really need to develop a love for humanity, a curiosity. I think that it's one of the coolest jobs in the world. It's kind of like medicine and law are two places where you can barely know someone and you get to know some really intimate details and you get to ask them some really deep questions pretty quickly. And you have to have respect for that privilege, because it is an honor that you're granted as a physician, that you can ask these kind of things, you can do these physical exams, and people trust you. So you have to have humanity, you have to have humility and be able to admit when you don't know or when you were wrong. Patients appreciate that a lot. Um, and you just have to be curious. You have to, when people tell you they have a problem, it shouldn't be a feeling of, oh, like another patient. It should be, like, that's, I'm sorry to hear that. Tell me more about it. And when it's something that's challenging, it shouldn't be a frustration to you. It should be, this is a great opportunity to learn. And I'm glad that I had a chance with this patient to stretch my medical knowledge, to kind of have to do some research to look it up. So I'll conclude, Amina, by saying humanity, a genuine interest in humanity, humility, knowing when you don't know and knowing when you're wrong, and curiosity are some of the things that make a great doctor beyond just medical knowledge. Adi asks, how do you stay committed even when tired? So this comes to knowing your why. Knowing your why. When you're getting into college and when you're getting into medical school, you'll have a really great opportunity to write something called a personal statement. And a personal statement is a self reflection on why you want to do what you're applying for, who you are, what you are, and why you feel that this is the right calling for you. This can be a combination of experiences you've had, stories that you've lived through, things that you've read, seen, heard that create your unique and individual why. So, for example, I told you guys earlier that I had some earlier circumstances that led me to medicine. I had a cousin who was very sick and sadly passed away from a particular kind of brain cancer. And so for me, he is my why. So even when it's 2 a.m. or I'm waking up at 5 a.m. to study, I'm reminded about my cousin and I'm trying to do what I can to kind of live through him and live for him and help people like him and families like his. And that's my unique story. Many people have a similar story, but my individual life experiences have shaped what that looks like. And it's kind of like the seven notes on a piano. Everyone has the same seven notes, but the tone you bring to it, the rhythm, the feeling you bring to it, create and cultivate a unique story. And so you need to figure out your why. If you're starting to get curious about this, you may not have some huge existential why. It might just be, seems cool. Dig a little deeper when you have a chance. If you're maybe next time you're on a walk or you're meditating, just think like, why do I find it cool? There's a lot of things in the world you could find cool. You could find engineering cool, you could find airplanes, crabs, I don't know, whatever. But for some reason you saw a video of an EKG or someone getting relief for a seizure or something, and you said, that's cool, I want to learn about that. Why? What about your life experiences made you interested in that? So the big thing, Adi, I'll say to this question of how to stay committed is knowing your why. And then other little things that can help, of course, are having a supportive friend and family group, people that can prop you up, so you can all be tired together. Me and my med school friends have studied plenty of times until late hours and woken up early. So staying committed is a matter of knowing yourself and having a team around you that can support you even when you're dead tired.
Thank you so much for that. We had a few questions from people who couldn't attend. One of the most frequent ones was if you've ever took like vital signs and you found out that the condition was more serious than you like originally thought. Like, how do you deal with that, and how do you like talk to the patient about that?
Great question. So more serious than you thought. For example, you have a patient that otherwise seems pretty normal. Things seem to be going well, and you take their heart rate, and it's pretty high. Maybe it's 120s, 130s, and you feel their pulse, and you notice that it's not regular. That you're feeling their radial pulse, and it seems to be skipping beats, or it's beat, 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 pause, beat, beat, beat. I had an example of that actually on my family medicine rotation out in a small town. This lady was just coming in for kind of an annual visit to be checked up. And I was able to feel a particular kind of arrhythmia, meaning out of rhythm pulse. And in that case, I called in the doctor that I was working with. I told her the patient's story. I explained what I was thinking to both her and the patient using language the patient could understand while keeping them calm. And I explained some thoughts I had for how we could further work this up and some next steps we could take, and gave the patient some options, make sure they understood what I was thinking. And you want the patient to be well informed, but you don't want to freak them out, right? So you say, here's what I'm feeling, here's what I noticed, these are my concerns. The way that I could find out more about this is, for example, with an EKG, so recording the heart's electrical activity. We can do some imaging as well, and we can take some next steps. Those might include X, Y, and Z, but we can come to that conversation when we have some more details. So those kind of things do happen, and you need to learn how to explain them to a patient in a way that calms them rather than freaks them out. One thing that you might think about is framing it in a way that says, I'm not glad that you're having this sign or this physical exam finding, but I'm really glad that we found it in clinic today. This means that we can get you the care that you need. I'm really glad that I'm not glad that you have high blood pressure, but I'm glad that you're in the right place, right? When you're in clinic with high blood pressure, you're in the right place. We can get you treatment. We can figure out why you're having high blood pressure, how we can treat it. So that's the way that you want to talk and explain it to a patient when you may not have been expecting it. You can remeasure, of course, to make sure you don't make a mistake. But if it's really something abnormal, you want to talk through it, figure out the options for the patient, and give them some relief.
Thank you so much for that. Another oh, Simriti, you can go.
Okay. Is there anything that you wish you had known before starting medical school?
I think the biggest thing that comes to mind as a practical piece of advice is I was very set in college that I needed to have science only majors. So I had two majors. I studied biology and neuroscience. Looking back, I wish that I had known that you don't really need all science. And I would have considered either getting a minor in English or doing, for example, neuroscience and English as a second major, because I do a lot of writing now, both scientifically for medicine as well as just for fun. So I'll take clinical experiences I have, and if they really resonate with me or they mean something to me, I'll write a poem or a story about that. And although I can do it without the English major, I didn't need to have that. It would have been kind of nice to formally study it and just have a little bit more breadth in my formal undergraduate education. And so I know people in medical school who are music majors, who are history majors. You can really do any major you want as long as you fulfill the pre-medical course requirements. So it's just something to consider going into college. Otherwise, that's probably the most practical piece of advice I can give you of something I wish I had known. But besides that, a lot of it you learn. I think that I expected med school to be a lot harder than it was. It's very hard, don't get me wrong, but I expected it to be like no sleep at all, just miserable the whole time. And I do a pretty good job. And at the same time, I still have time to exercise, run, and all of that comes down to good, healthy time management. So on the bright side, come into medical school knowing that you still have time for a life. And in fact, you should live a life because you want to be human with your patients.
Thank you for that response. Another frequent question that students had for this meeting was that why do you think like a lot of people choose to become a doctor, or like why are you choosing like the doctor route versus like becoming something like a PA or a CRNA or like an RN, and what makes like being a doctor so distinct, especially since it's such like a long and like a really hard journey and rigorous?
That's an awesome and really forward-thinking question. So all of the roles in healthcare are important. They all have distinct responsibilities and tasks. And if you're interested in healthcare, you really need to explore which of those is right for you. There's not, whatever is right for you is right for you. You don't have to worry about, oh, but a PA isn't a doctor, a nurse isn't a nurse practitioner. Figure out what you like, and that's what matters. But in terms of myself, and I think some of my peers distinguishing that, I do still believe that there is something very distinct about the role of a physician. I see the physician as there's an ancient word, iatros. Iatros means healer. And I really believe in the physician as this pillar of healing in a community, that while many people can play a role, the physician encompasses all the aspects of that role. They are the leader in the room. They are the person who takes responsibility and says, I will make this decision. I will take your hand and guide you. And again, while PAs and other people can do that, I do think that there's something about the physician that allows you to do that in a very all-encompassing way. It's almost spiritual, not in a religious sense, but in a person-to-person sense, that you are giving another human being trust of your life. When it's something really serious, that physician is someone you should be able to trust as a friend, as a professional, as someone who really cares about you. And so for me, I want to work in a small town ultimately. I want to do rural family medicine where there may not be a lot of other providers. There may not even be a lot of other nurses or other healthcare professionals. And I'm very interested in taking on that responsibility of all those roles. I want to be someone that can earn the trust of my patients to say, I'm going to do my best to make you feel better. I'm here for you. And I do think the physician role is best suited for that all encompassing role that allows you to do procedures, allows you to do all the history and diagnosis and prescription of medications. So it allows me to do a lot and also has a traditionally um, distinct role in the healthcare realm. Again, think about what is important for you. If that sounds like what your calling is, then pursue it because you're right. Whoever asked that question, it's not a good way to make money. There's way better ways to make money than being a doctor. Um, so you can't go into it for the money. You can't go into it for the prestige. You have to truly have a love for healing and humanity and um, know that you're willing to go through all those years of training to earn that privilege and that trust from your patients.
Thank you so much for that response. One last question just to end off of. I think a few students asked about like this fear of like having to be perfect as like a physician, like having someone's like life in your hands, or just like making sure and like feeling as though like one slip up is just like end all be all. Like, what advice do you have for that, and just for like students who feel like they might not be like good enough to be a physician or they don't have that level of perfect?
Wow. I think that I'll start from the physician slash resident slash medical student end and then come back to the last point of people in y'all's position in high school. It's hard even as a medical student. I think a lot about my patients. I think about decisions I make with them in clinic, in the hospital. Did I make the right call? Did I put the right dosage in? Should I have followed up more regularly? If you haven't heard from someone in a while, you start worrying and thinking about them. And it frankly never leaves you. Even from the old physicians I talk to, the middle-aged physicians, it's hard. Anytime someone walks in your clinic, if you have to make that decision, do they need to go to the hospital or can they go home? And it's a hard decision to make, but as you gain experience, as you gain knowledge and wisdom is probably the big word here more than knowledge. You start to have an understanding with your patients. You start to make shared decisions with them, and you learn to live with that. At the same time, other ways that you can cope with some of those challenges are through writing. I'm a big advocate that those kind of emotions, experiences, you really should translate into writing, whether it's just personal into a journal, or expressing those feelings. If it's fictional, making it into a story or poem, talking with other people, consulting with them. You can always ask for help. That's probably the most practical piece of advice here is you can always ask another physician or a teammate or a nurse or the patient's relative, spouse, child for help. Hey, can you make sure to call me tomorrow or call the office this evening to let me know how things are going? There's ways to have some kind of mental insurance to check up on them. But then when they're just out of your sight and you don't know, did I do the right thing? You really have to, one, trust yourself, two, develop that wisdom over time, and three, find healthy ways for you to cope with it. And I emphasize healthy because sadly, um, many physicians and healthcare providers don't find healthy ways. Physicians are one of the highest rates of suicide. Dentists are actually even higher because they own their businesses. So it's a really challenging situation. But physician suicide is a really big thing. Psychiatrists are one of the most hard hit for that because it's hard. You got to find healthy ways to cope and avoid things like despair, alcoholism, drugs. So finding healthy ways to cope, developing wisdom, checking up on the patient more frequently, and asking for help. Just consult, refer, find one of your buddies from medical school or residency and say, hey, I decided on this medication for this. What do you think? Would you have done something different? And so that doubt never leaves you, really. And it's actually somewhat of a good sign that you have a bit of humility, that you're not just, no, I'm perfect. Nothing I do is wrong. You should have a little bit of doubt and humility, but learn to respect your wisdom and the things you've learned, and know that you're probably making the right decision most of the time. At y'all's level, this is, am I good enough? It's so hard to know, right? Because especially in our age right now, you're not only comparing yourself to the people in your classroom, right? You can compare yourself to people all over the world. And while that can be a good thing because you can share ideas and share notes, that's so hard when you got to compete with someone in your head who's across the country and doing 30 projects and doing all this. Am I good enough? Why can't I be like them? And ultimately, you can't let any of that stuff get in your way. Let other people do their work, let them find ways to excel, and try to use it as motivation if it's something in your mind, and just focus on yourself. Focus on what you can do every day to be a little bit better. How can the you today help the you tomorrow? And know that if you're trying your best, and I really do mean trying your best, you have to ask yourself that question: am I trying my best? If you are, then you're on the right path. Sometimes we have to reframe, because sometimes we ask, am I trying my best? And we say, oh, maybe not. Maybe I'm playing a little bit too much video games. I'm socializing too much. And that's okay too. But just be honest with yourself and figure out ways to be comfortable with what you're doing. And if at the end of the day you say, yeah, I really gave it my all, then things will work out. There's always going to be ways to achieve your goals. If you ask for help, if you are humble, you don't allow comparison with others to drag you down, but instead to motivate you. And if you find good, healthy coping mechanisms to move forward. And I think even just by coming to events like this, it really shows, and maybe listening in if you're on YouTube, that you guys are trying hard and you're really thinking ahead for your future. So I applaud y'all.
All right. Thank you so much for that response. That was very insightful, and especially for me because I really am thinking of so many different healthcare careers and just which one I want to enter into as I become a senior. So, yeah, thank you so much for this very insightful Zoom call, and especially since we actually got to it was very interactive and we actually got to do practice these clinical skills, and we also got to have a Q&A. So I personally really enjoyed this Zoom call, and I want to say thank you to everyone who joined, and a big round of applause for taking the time out of your day to help high school students. So I think that shows your true passion and just doing this volunteer work even though you don't have to do it. So thank you so much for that. And yeah, thank you for everyone who joined. And I think this is the end of the meeting.
Great. Thanks so much, Maya. I put my email in there. Guys, feel free to message me. I'm always happy to help, whether it's about preparing for college, thinking about the right career path, like Maya's saying, thinking about different spots in healthcare. So please shoot me a message. Thanks again for coming, and I'll see you all around.
Bye.
Bye. Thank you.
Thank you.